Good afternoon and welcome to today's Lunch and Learn on infants entering out of home care, developmental trajectories and services. Firstly, can I introduce myself? My name is Stuart Moucher and I'm the Acting Executive Director of Family and Community Services, Insights, Analysis and Research, otherwise known as FACSIAR. Before we begin, I'd like to acknowledge that wherever we are joining today's webinar from across New South Wales, that we are all living and working on Aboriginal land. I'd personally like to recognise the First Nations people of the Earlwood area, where I have the privilege of joining from today, that being the Bedjigal people. And I would like to acknowledge and pay respect to all First Nations elders, past and present, and to future and emerging leaders. And I'd also like to extend that respect to any Aboriginal colleagues that are joining us today. So a very warm welcome to all our webinar participants that we have with us today. In particular, a special welcome to our speakers, who I will introduce in a moment. But I'd also especially like to welcome any frontline colleagues that we have joining us today from one of the DCJ districts or from one of our many not-for-profit partners. So what are we here to talk about today? Regrettably, the number of infants in Australia entering out of home care during the first year of life due to child protection concerns is increasing. And we know from research that infants and toddlers entering out of home care have the highest rates of substantiated notifications of maltreatment and are at much higher risk of developmental vulnerability, poor health and attachment problems compared to infants who have not been maltreated or placed in out of home care. So this FACSIAR Lunch and Learn will focus on the current research and practice to improve the health and developmental trajectories of infants entering out of home care and the best way to support them and their carers. So findings will be presented from the Pathways of Care longitudinal study, our POCLs. You'll also hear an update from the New South Wales Health First 2000 Days Framework. You'll hear an overview of the research and practice on how best to support foster and kinship carers of infants. And along with that, you'll get information about the Health Pathways program for children entering out of home care. So now I would like to introduce all our presenters, and then we will flow through their presentations without stopping. We're very honoured to have these presenters here sharing their insights into what is an incredibly important area of research. So first up, we will hear from Associate Professor Elizabeth Murphy, who is the Senior Clinical Advisor, Child and Family Health at the New South Wales Ministry of Health. And Dr. Murphy is also the Director of Child, Youth and Family Health Services at Northern Sydney Local Health District. She has been involved with the development and implementation of the out-of-home care pathway since its inception. She's also a recipient of the Royal Australasian College of Physicians Medal and was recognised as one of the top 50 public sector women in New South Wales. Her talk is titled Infants Entering Out of Home Care, the First 2000 Days Framework Perspective. Next, we will hear from Associate Professor Melissa O'Donnell. Melissa is the Deputy Director and Associate Professor at the Australian Centre for Child Protection at the University of South Australia. Melissa is an internationally recognised researcher in the area of child maltreatment and vulnerable children and families, and has utilised population-based administrative data for over 15 years to contribute new knowledge and evidence. Her talk is titled Infants Who Enter Out of Home Care, Child Protection and Developmental Trajectories, Research from POCL Study Analysis. Next, we will hear from Associate Professor Stacey Blythe, who is a registered nurse and a research academic. Her research focuses on the health and wellbeing of children in out-of-home care and their families, biological, foster and adoptive. As a lecturer in infant mental health, she is particularly interested in infants who are prenatally exposed to harmful substances. Stacey has also been an authorised carer for over 16 years. So Stacey will be drawing on her skills as a nurse, her knowledge as a researcher, particularly in developmental trauma, and her experience as a carer today in her talk entitled Foster and Kinship Carers of Infants, How Are They Prepared and Supported in Their Caregiver Role? Last but certainly not least, we have Angela Tocker. Angela is a Program Officer in the Child and Family Directorate in the Department of Communities and Justice. Angela has experience in human services, policy and program design and implementation at both the state and local government level. Angela's current work involves the development and implementation of programs to improve health outcomes for children and young people in out-of-home care, and her talk is titled Health Pathways Program for Children in Out-of-Home Care. So as you would have heard, we've got a very full run sheet, and after the presentations, with any time we have left over, I'll lead a Q&A session with our presenters. So can I please ask any questions that you have? please pop them in the chat through the presentations, and I'll do my best to come to those at the end. Finally, just a reminder that today's session is being recorded and will be posted on the FACSIAR webpage. And so anyone who's RSVP'd for the webinar will receive a link to the recording in the next week or so. So with all that said, can I please hand over to our first presenter? A very warm welcome to you, Associate Professor Elizabeth Murphy. Thanks very much.
Thank you so much for that introduction. And can I say it's an absolute pleasure and privilege to be part of this wonderful FACSIAR Lunch and Learn today. I'm from New South Wales Health, and I'll be speaking about the work that we're doing on the importance of the first 2,000 days of life. And why is it important? Essentially because those 2,000 days set the potential for the next 30,000 days of life. Tragically, that life expectation is still not the same for Aboriginal and Torres Strait Islander children. And I would also like to pay my respects to elders past, present and emerging, and acknowledge that we're meeting on many different Aboriginal lands today. So those first 2,000 days, this new evidence is actually incredibly powerful to all of us because we've all experienced that first 2,000 days, or might even be responsible for children in our own care or related to us. So I'd like to put a warning that some of the evidence that I'll be talking about could be distressing, but that it is public health risk, not individual risk, not individual clinical risk. That risk is never destiny. There's always the human capacity for resilience. And as we know with any experience of children in out-of-home care, there is never any one thing that will determine an outcome. And so not acknowledging that rich tapestry, I would like to also emphasize this is new evidence and just run through some of it in the sort of alphabetical A, B, C, D, E, and begin where it does begin, which is in the antenatal period. Now, I can't deal with all of the different aspects of what happens in this antenatal period, but I would like to emphasize just one component, and that is the new emerging evidence that the psychosocial health of the mother is directly impacting on that child's psychosocial health and what they will be manifesting later in the way they behave, in the way that they relate, in the way that they learn. There are some very basic studies, some wonderful studies from our own Western Australia, which is a cohort study of nearly 3,000 women from 89 to 90, and has been followed up for many decades now. But one of the things that they looked at was the stressful events that happened in that woman's life. Not excessive stresses, as we may see with some of the out-of-home care population, but the kinds of things that can happen in life. And when they did, they found that there was a risk if that mother had experienced more than 4 to 5 stressful events in the pregnancy, of that child showing an abnormal result on a child behaviour checklist 10 years later. So what's happening to the mother is impacting on that child. And a lot happens to the psychosocial health of mothers and fathers in pregnancy. We know that a significant number of women will get depression or anxiety as a result of the pregnancy. In New South Wales, that would be 10,000 antenatally, 17,000 postnatally getting depression as measured by our Edinburgh Postnatal Depression Scale. And that's the general population, not some of the populations that we may be dealing with that are more vulnerable. And this evidence is continuing to grow. We now have images from MRIs that are showing that pathways that should be developing from the prefrontal cortex to the amygdala are not happening where that mother may have significant depression or anxiety in that developing fetus, in that developing baby in the womb. And a study recently from New Zealand, which is a longitudinal follow-up study, which showed that mothers with mild to moderate stress in pregnancy can have adverse outcomes on that child's neurodevelopment or executive functioning, which impacts on how that child learns. So just beginning to understand how much is happening in the womb. And in particular, I obviously have to mention the impact of alcohol in pregnancy. if you have a look on the right, that graph there that shows the purple, that is the load of fetal alcohol spectrum disorder of the causes of all neurodevelopmental disorders, developmental disability in the Western world. So you can see what a massive impact that's having, and yet it's 100% preventable. And the consequences are so serious. This is a study that showed that in the Juvenile Justice Institution in Western Australia, 1/3 of the young people there had the primary diagnosis of fetal alcohol spectrum disorder. So much else is happening in the womb that will determine what kind of illness that child might have in later life. So now moving to the brain, also looking at the context of when a child is born. So we've talked a little bit about brain develop in the womb, but when that child is born, there are trillions of neurons not connected, and how they are connected is determined by the experience of that baby, in particular, as we're talking about today, in that first year of life. And the reason why it's in particularly important in the first year of life is because look at that head circumference chart. Look how steep the chart is in that first year of life, and think that that is affected by the experience of the child. So are the circuits that are going to be formed ones of loving and security and consistency, or are they going to be formed of anger and aggression? And that will be as a result of what kind of experiences that child is having, in particular in that first year of life. Experience determines neural connections. Now, we know a lot about this from the Romanian orphanage study, because that study actually demonstrated extreme neglect. And you can see in the PET scan there on the right that the neuronal development just didn't actually even happen, as opposed to that healthy brain on the left-hand side, where there was warm, secure influences on that child, that the experience of that child were like that. The other thing that we know now is that there is a time for development, that there are sensitive periods where there'll be rapid growth in brain development, and then that critical period wanes. And you can see that in this image on this chart, but you can also see it in this chart here that's talking about the rapid growth times. And that, of course, is when you are talking about children in out-of-home care, in particular in that peak period in the first years. And you can see how much brain development is happening in that sequential order, and that needs to be not disrupted, that we need to ensure that children are getting a loving, secure environment during that time. Indeed, a study from the UK has determined that we can predict educational outcomes at 26 years by a developmental score at 22 months. And developmental surveillance is how we can determine how a child is going, looking at those different domains so that we can see how that child is responding to the experience that they've had. And finally, I just want to talk about one study. We've talked about brain development. Let's now talk about body biochemistry. And this study was one that was done about negative experiences in the early years have a long-lasting effect that can be difficult to overcome later. And this is called the ACE study, made quite famous, if you haven't seen it, by a TED talk by Nadine Burke-Harris, where she, for 15 minutes, explains this study very well. But essentially, it's a score out of 10. And essentially, it's what's happened in the child's life. 3 for the different types of abuse, 2 for different types of neglect, and 5 for what's happening in the household. And if that score is 6 or greater, the prediction is that that child will die 20 years earlier. But ACEs are common. ACEs have been, this study has been replicated in many countries, and essentially it's not uncommon, but it's where we get to the top of that high level of ACEs that we should be concerned. So what's happening is stress, that child has got stress hormones and is set at a level of toxic stress. So they're constantly set in flight and fight. So there's no point in saying to them when they try drugs for the first time that there's something wrong with taking drugs, because they've just felt normal for the first time in their life. So you can see the impact of domestic violence, the impact on the mother antenatally is going to affect that child, and the impact on the child. Epigenetics we can't get into today, but you can see that whether we want to turn on what would be a good response or a negative response is all determined by that baby's experience, and that's the work that you're doing. Now, the good thing about this evidence is that we understand the mechanism. We know the anatomy, the biology, the biochemistry, the DNA, the epigenetics. And if we understand the mechanism, we can understand the interventions. And the interventions all come down, I would say, in the main to this very first one, attachment. But let's just run through these. Now, attachment, just skin to skin attachment, we know is important. In Scandinavian countries, they have constant kangaroo care, and these babies leave neonatal intensive care earlier because of physical attachment. But of course, we mean so much more. We mean that loving, consistent caregiving, that mutual gaze between someone who adores this child, rather than that child's gaze being one of flight and fright. And your role in ensuring that those children have placements, that they have continuity of care, that they have continuity of carer, they have connection with their biological family, that they have developmentally appropriate and enriching environments, but basically the importance of attachment. That is so important for this child to be able to get the best opportunity in life, especially as we've discussed that this is the most important time from a brain plasticity perspective. This is where you can make the most extraordinary differences and repair, if you need to, what has happened. And we know that the interaction between that caregiver and the child, that serve and return, that loving response is absolutely critical to this child's chance to become an adult that is able to live, love, and learn to their potential. Now, we've all seen these children, haven't we, that no matter what life's thrown at them, they're resilient. And this has been shown in the Romanian orphanage studies, that 20%, no matter what, have lived this life that we would want for all, but 80% don't. So we need to look at how we can build resilience, because that is our work. We can turn this child's trajectory around by building resilience, by making sure that they have an accumulative effect of positive life experiences. And this is what we talk about in the first 2000 days. There are 3 objectives, but the important one for today is this objective 3, that we provide more to those who need more. And brilliantly, first 2000 days is now embraced at an interagency level by Brighter Beginnings, because if there's one thing for sure, we can't do this on our own in health. And it's just thrilling that we are doing this in partnership with our other agencies, and in particular with communities and justice. Is there any more important group of children than those where we all have responsibility for at this state level, those children who need us to support them to make sure that they can get the best care? So, if you haven't looked at it, the webpage on Brighter Beginnings is just brilliant, listing all of the resources that are available. And I just wanted to finish with talking about the kinds of things that we offer in health. So first of all, it's the out-of-home care pathway, and that is that every child going into care gets a health, developmental and dental assessment. Often it's the dental assessment, I must say, that the foster carers are so grateful for. But we do this assessment on all children and repeat that assessment to monitor how they're going and to provide an intervention if they need extra help. That's our out-of-home care pathway. But when we're doing that, we can look at whether there are other things. Often these children may be called difficult, but is that something in response to stress or trauma, or do they have a developmental vulnerability? That's all a part of what we hope to be able to offer. But one of the things that I think is just brilliant that we are also working in partnership with DCJ, and that is pregnancy family conferencing. That's working with a mother and the family and the resources she's got during that antenatal period, because we know that's going to affect that child, to make sure that we can give the best outcome in a child that might need to be assumed into care. And even if that does happen, at least that mother and that child know that they tried as hard as they could during that period to be able to be a parent to that child. A wonderful program. And if you think about the parent, it also makes us change from saying what's wrong with you to what happened to you, if you think back to the ACE study. Now, brilliantly, we've got extra funds for pregnancy family conferencing. That was just announced at this Brighter Beginnings launch. And you can see that we've got an extra 38 million to do pregnancy family conferencing, which is just thrilling because I think this could make a huge difference to the outcomes. So we look forward to making a difference, not just for this generation, but for the next, by working in partnership with DCJ. And now I'll hand over to my colleague, Melissa. Thank you.
Thanks, Elizabeth. It's a good segue into my research, which is looking at infants who've entered out-of-home care. And we're particularly focused on the child protection and developmental trajectories of those children. I also want to acknowledge the owners of the lands we're all meeting on today, as well as the lands that I'm on, which is the Whadjuk people of the Noongar Nation in Western Australia. And I'd like to pay my respects to all the elders. So as was said previously, across Australia, infants are overrepresented in the child protection system. So they're the age group who receive child protection services at the highest rate. They have the highest rate of substantiated notifications of maltreatment and the highest admission rates into out-of-home care. And we do know there is an overrepresentation of Aboriginal infants involved in child protection, with Aboriginal infants being removed from their families at 10 times the rate of non-Aboriginal infants. And I just wanted to acknowledge the work of the Safer Start Coalition led by Catherine Chamberlain, who have recently published a paper on Aboriginal-led strategies to address this overrepresentation, which is an important closing the gap priority. As was said, international research evidence has found that infants and toddlers entering care are more likely to have poorer health. They're more likely to be born premature or low birth weight, potentially have neonatal withdrawal syndrome, to display attachment problems or emotional and behavioural problems. And these developmental vulnerabilities, as we've heard, can impact on longer-term outcomes such as school readiness, educational achievement, social behavioural issues and mental health conditions. However, there is a gap in terms of the research evidence on infants entering care in Australia, and this is essential for ensuring that we're optimising outcomes for this vulnerable group. So the aims of our research really was to determine the child protection and developmental trajectories of children who entered care as infants, and determining whether meeting their developmental needs through service provision improves trajectories and outcomes for these children. So we used the Pathways of Care longitudinal study, which is a New South Wales study, and it's the first large-scale prospective longitudinal study of children and young people in out-of-home care. It was the first study to link data on children's child protection backgrounds, their out-of-home care experiences, their health, education and offending, held by multiple government agencies. And they've used survey data, which is collected from children, caregivers, caseworkers and teachers, to match that information to the administrative data that's been collected. So just to give you an understanding, that's a census of all children and young people who entered out-of-home care for the first time in New South Wales between 2010 and 2011 and received final children's court orders by 2013. In terms of the sample we're interested in, which is predominantly the infants, there were 370 infants in the study who were aged less than 1 year when they entered care, and whose carers participated in the 3 waves of the survey data. So that we had linked data from New South Wales perinatal data collection, the New South Wales admitted patient data collection, and the child protection data. And standardised screening tools were conducted with the carers. So the Ages and Stages questionnaire has been used, which is a screening tool of infants and young children who are at risk of developmental delays, and it's completed by the caregivers. So they assess domains such as communication, gross motor, fine motor skills, problem solving, and personal and social. And they use a cutoff score to determine whether a child is developing appropriately, or whether they require closer monitoring or assessment. They also had the brief infant toddler social emotional assessment, which is a screening tool that identifies children aged 12 to 35 months that may require further assessment to identify clinically significant social and emotional and behavioural problems. And as was mentioned by Elizabeth, the child behaviour checklist is also used across many services, and that assesses internalising and externalising behavioural issues. And that's for children who are aged 3 and above. So just to give you an understanding, our infant sample, so we know that there are a large number of children with disability in the child protection system. And as you can see, in terms of the infants that enter care, there was around 18% of children that had a disability. There's a large proportion of infants who came from socioeconomically disadvantaged areas. And these infants are entering care predominantly very early. So as you can see, 43% entered care within the first 3 weeks. And overall, over 2/3 of the children, so around 70%, entered care for the first time in the first 3 months of life. So they're entering very early into the system. At birth, 22% were identified as having low birth weight, and 1/5 were born preterm. In terms of their child protection trajectories, the majority of children who entered care as infants were still in care at wave 3, so aged 5 to 7 years. 13% were in kinship care and 80% in foster care. 19% did leave care, with the majority placed on guardianship orders, with small numbers adopted or reunified with family. There are a high number of infants with developmental concerns at wave 1. So 65% were considered at risk of physical and cognitive developmental concerns. However, we did see this risk decline over time to about 36% by wave 3, which is still a large proportion. And social and emotional concerns were lower at wave 1 at 20%, but they rose to 30% by wave 3. In terms of access to professional services, in wave 1, there was only 18% receiving professional services for developmental issues. However, this did rise to 45% by wave 3. It was really difficult to determine why children who were identified as having developmental concerns were not receiving professional service, but those that did respond said that some of the reasons they weren't receiving services were due to waiting lists. So we know that that is an issue across Australia, and it's been mentioned in New South Wales, particularly during COVID, the waiting lists have been blown out, and that's a real concern in terms of, the 2,000 days framework in getting support and interventions early for young people at risk and children at risk. In terms of at-risk children, for children identified as at risk of social and emotional concerns, 31% were receiving services, and this rose to 66% by wave 3. And for those at risk of cognitive and physical concerns at wave 1, it was lower at 21%, but that were receiving professional services, but it similarly rose to 66% by wave 3. We really wanted to understand whether there were different trajectories among the infants. So I won't go into what group-based trajectory modelling is, but just to let you know that group 1, in terms of cognitive and physical developmental concerns, was around 55% of the infants. They had a lower probability of being at risk of cognitive and physical delays, and they did show decreasing developmental risk over wave 2 and 3. And these children were more likely to be females. And we know that males obviously have more, there are more concerns about their developmental trajectories over that time. So it's consistent that females were more likely to be in that lower risk group. In terms of group 2, which was 45%, they had a higher risk of developmental delay at wave 1, which declined over time, but at a smaller rate than group 1. But what was reassuring was that group 2 were more likely to be receiving services. So this is the group that do need sustained support because they're not showing the gains over that period. In terms of social and emotional concerns, this was different. So group 1, there was around 80%. So they were at lower risk of social and emotional issues at wave 1, and they remained relatively stable over the 3 waves. However, of concern is that there was a group 2 which had 20%, and they were identified as at risk for social and emotional developmental concerns at wave 1, and they actually demonstrated worsening risk of social and emotional concerns over time. There are a number of factors that distinguish these two groups. So girls and those in kinship care were at lower risk of being in group 2 for worsening social and emotional concerns. And we know that connection to kin is very important for wellbeing, particularly for Aboriginal children. They were also more likely to have 3 or more placements, which we know is another concern, but we're not sure if this is due to the development, the behavioural and emotional concerns that they display, which might be, difficult for carers to manage. Therefore, carer support is really important, as well as providing the support for the child in terms of meeting those needs. They were also more likely to have a disability. And we know that children with disabilities are at high risk of social and emotional issues, and it's really important that we provide holistic support for these children. In terms of the key findings and implications, so the majority of children who enter care as infants will remain in care through their childhood. There is a high level of developmental vulnerability, as we've discussed in the infants, and a large proportion of infants did have positive cognitive behavioural developmental trajectories, with service provision increasing over time. But we did still see a large group who require support, ongoing support to sustain improvements. It's really important, as we've said about the 2000 days framework, to ensure service provision is provided early in their development. So that's why it's so important we can speak to you today about this, the importance of identifying early and providing the support early for those children who need it. In terms of social and emotional development, we did find there to be a difference. There was a group of infants who had early social and emotional concerns who displayed worsening trajectories, and interventions for this group is an important priority to reduce the risk of poor trajectories and poor mental health outcomes. And as we've said, it's important for infants to have ongoing health and care plans. And it's particularly important given the high proportions of developmental concerns identified in infants entering care. And New South Wales, as was mentioned, do have an out-of-home care health pathways program. So it's important that health, wellbeing and cultural plans are developed for children. Caseworkers have an important role to play in working in partnership with carers, families and children to ensure the children's needs are being identified and they have access to the services that meet these needs, and that these are reviewed regularly. And given the high proportion of infants staying in care, it is imperative we ensure that there is the support to optimise and strengthen their outcomes. And if the child is able to be reunified with family, that this support is sustained. And I just want to acknowledge the study team who worked with me, particularly Fernando Lima, who did the analysis for us, as well as the Pathways of Care Longitudinal Study Working Group. And I'd now like to pass over to Stacey Blythe for her presentation.
Thank you, Melissa. That was fantastic. I would just also like to take a moment to acknowledge that we are on Aboriginal lands, and I am currently presenting from the land of the Darug Nation. I pay my respect to elders past, present, and emerging. I'd also like to just briefly acknowledge the rest of my research team and say that the study findings that I'm presenting today come from a partnership grant between Western Sydney University and Adopt Change. So as it's already been said several times, infants are a vulnerable population and they are highly represented in the out-of-home care system. So rather than repeat that, let's just move on and talk about the fact that carers are likely to be the ones providing most of the care to infants, foster and kinship carers. And there's emerging evidence that carers might be lacking in skills related to infant care. For example, a study we conducted a couple of years ago looking at infant feeding in the out-of-home care context, we uncovered that over a quarter of the respondents to that study had no biological children of their own, and therefore it had no antenatal or postnatal training with a qualified healthcare professional to attend to basic infant needs like bathing, feeding, and settling. And this is a particular concern given that the majority of infants and young children placed into out-of-home care are known to have increased incidence of physical, mental, developmental health issues compared to the general population. And for many, this includes specific issues related to prenatal substance exposure and developmental trauma. Foster and kinship carers have a significant responsibility to ensure the health and well-being of the infants in their care. However, whether or not these carers are actually receiving specific training and or support to care for infants, many of whom have increased healthcare needs, hasn't been largely investigated. So we did. We used a mixed methods design using an online survey and individual interviews with carers. Ethics approval was granted via Western Sydney University. So what did we find? We had a total of 232 respondents who gave complete answers. To be eligible, they had to have received care of an infant in the past 5 years. So that was from 2015 onwards, because we wanted to capture a contemporary picture of practice. There was representation from all Australian states and territories, with the majority being in New South Wales. The majority of respondents were foster carers compared to kinship carers, which was only 12%. And overwhelmingly, carers identified as female, and the majority were also married at 64%. And of the 232 respondents to this study, 1/3 reported that they'd had no biological children of their own and thus no previous parenting experience. The length of time of providing care, the experience of providing care for these respondents varied significantly, with 1 to 5 years being the most common reported, and that was 86 of them. And the number of infants that they had cared for was also considerably variable, but the majority had provided care to only 1 infant. We asked questions regarding the arrival of the infant and found the majority of the infants were either transported to the carer's home by the caseworker or the carer collected the infant from the hospital. More than half of the infants placed were less than 1 month old, which coincides with what Melissa found. And the infants, with 1/3 of the infants being less than a week old when they were placed into care. So very, very young, very vulnerable infants. Approximately 1/3 of the infants were actually visited by a community nurse or midwife in the carer's home, and 3/4 of the infants were taken for visits with the community health nurses by the carers while they were in care. We asked questions about 8 different topics related to the care of infants in out-of-home care to gauge what sort of information, support, or training was provided to carers. We also looked to see if the responses differed between carers with biological children and carers without biological children. We found that overall, just under 1/3 of carers reported receiving information or training related to infant feeding. This is things like bottle use, teat selection, sterilization, things like that. But of these, 23% of them indicated that they sourced this information themselves. Overall, just 1/4 of the carers reported receiving information or training related to infant nutrition. That's formula selection and when to introduce solids and things like that. 35% reported sourcing the information themselves out of that 1/4 who actually got it. Overall, just over 1/5 of carers reported receiving information or training related to infant immunization, and of these, 43% sourced that information themselves. Less than 1/5 of the carers reported receiving information related to infant bathing, sleeping, and settling, and again, of these, 30% report sourcing that information themselves. Less than 1/5 reported receiving information or training on developmental milestones, with 60% of those reporting that they sourced that information themselves. 1/3 of the carers reported receiving information or training related to infant attachment and developmental trauma. When we consider the 8 categories together, it was found that 41% of foster carers did not receive any information or training at all related to infant care. 28% received training in 1 or 2 areas, and the remaining 30% received training in 3 or more. The majority, however, report sourcing the information or training themselves. We asked questions related to training and whether or not support was required. The great majority of respondents agreed that specific training related to infant care should routinely be provided to carers, and that they themselves would have benefited from such training. Overwhelmingly, respondents indicated that infants in out-of-home care should be receiving in-home visits from nurses and attending community health clinics. This study sought to explore the experience of providing out-of-home care to infants in order to understand how to best support carers in their caregiving role. And results indicate that overall, carers are not well supported. and significant differences were present in training given around basic infant care with carers who had no biological children of their own compared to those who had biological children. Although more likely to receive information and training, those who did not have biological children of their own, really only 1 in 3 received training, and most of that was self-sourced. Information and training related to infant attachment and developmental trauma were most commonly offered to carers. This reflects a growing understanding and acknowledgement of the importance of primary attachment relationship for healthy infant development, and it also demonstrates an understanding that infants can and do experience trauma. Trauma can significantly interfere with early child development and can disrupt attachment, delay language acquisition, impede social skills, and inhibit emotion regulation. Infants who experience trauma often fail to meet developmental milestones in a timely fashion. However, you need to know these milestones in order to recognize that the infant is not meeting them. And this study showed not all carers did. The results of this study indicate that not all carers have access to this important information, and the infants at their care may inadvertently be at risk of becoming developmentally behind. Positive attachment relationship with a primary caregiver is fundamental to healthy infant development, and this attachment is especially important for infants who have experienced trauma. But it may also be difficult to develop as some infants may withdraw, avoid eye contact, fail to give off cues, and regularly self-soothe rather than seek out nurturing from their primary caregiver. Carers who have an understanding of this are more likely to proactively engage with infants in order to foster that attachment. However, if carers are not aware of this, infants can become increasingly disengaged and fail to develop along a typical trajectory. It's concerning that so few carers were provided with information on basic infant caregiving. This is particularly troubling for those carers who have not had children of their own. The majority of these carers would not have had guidance or from a health professional antenatally or postnatally. Perhaps there is an assumption as well that carers who've had their own biological children already know what they're doing as they've had infants before. But the survey indicates that those carers with their own biological children are older, averaging 45 to 55 years. It's likely based on current childbearing statistics that their own biological children are at least 10 years of age. 10 years is a long time between infant caregiving periods. It's clear that basic infant caregiving is not routine training delivered by the out-of-home care system, and one may ask why. It may perhaps be because this is viewed as an issue which should be addressed by the healthcare system, and that's not illogical. Nurse home visiting programs are designed to support infant and parent, ensuring that the identification and intervention for troublesome issues, enhancing attachment and bonding, and increasing safety in the home and improving parental self-efficacy. Unfortunately, this study found that only 1/3 of infants and their carers received visits from a nurse or midwife. Why are these infants not routinely being seen by home visiting services? It's likely due to poor referral pathways, as generally it is the mothers, not the infant, who are referred, and this occurs during pregnancy or birth. When the infant is separated from the mother, there's no alternate referral pathway. So based on our study, the recommendations that we've put forward is that carers desire and are likely going to benefit from basic infant caregiving training. Training related to attachment and developmental trauma should be provided to all carers of infants and be infant specific. Nurse home visiting services should be available to all infants and carers in the out-of-home care system. And further research should investigate specialized nurse home visiting services that can provide additional information to carers related to attachment, developmental trauma, and prenatal substance exposure. Thank you very much. And I will now pass over to Angela.
Thank you, Stacey. I'd also like to acknowledge the Darug people who were the traditional owners of the land of Parramatta, where I am today, and pay my respects to elders past, present and emerging, and any Aboriginal people who are here with us today. I'd also like to thank the FACSIAR team and particularly thank them for inviting me to be part of today's Lunch and Learn session to share some information with you today about the out-of-home care health pathway for children and young people in care. The out-of-home care health pathway is a partnership program established between DCJ in the Ministry and the Ministry of Health in 2010 to improve health outcomes for children and young people in statutory care. And as Liz mentioned previously, this is done through providing children with regular health assessment, planning, service provision, monitoring and review in a coordinated and systematic way. The pathway eligibility is for children and young people who entered care after 2010, or for those who entered prior who have a significant health need. And once children turn 15, they should be referred to the pathway regardless of when they entered care. The pathway is supported by an out-of-home care health coordinator in each local health district who are responsible for coordination of the process. And they're a great resource for our local DCJ and NGO caseworkers because they can provide more information about the specific steps and processes, but also provide very helpful information about local health services in the area and how they can be accessed. And I've included in my presentation today the details of the out-of-home care health coordinators for people to refer to. This diagram on this particular slide provides an overview of the pathway process. It includes timeframes for when key steps need to be completed, and the colour coding on the diagram provides an indication of where stakeholder responsibility lies. So the key stakeholders in the pathway process include DCJ, health, NGO out-of-home care service providers, carers, birth parents, and also children and young people themselves. So once referred to the pathway by DCJ, all children and young people should undertake a primary health assessment of their physical, developmental and mental health. And that should occur within 30 days of entry into care so that their needs can be identified as soon and as early as possible. For many children, the primary health assessment will identify the need for a more comprehensive health assessment to take place. And this is usually done by a range of health clinicians across different health disciplines. All children and young people should receive a health management plan, which is a document that outlines their health needs and how these health needs will be met. The health management plan includes actions for health practitioners, for caseworkers, carers, and children and young people themselves. And all stakeholders should work together to make sure that the plan is implemented. And implementation includes ensuring that the actions from the health management plan are incorporated into the child or young person's case management plan. Review of health management plans is also a very important step of the pathway process because children's health needs change over time. And the review schedule is determined by children's clinical need and also their age. So at a minimum, children who are under the age of 5 should have their health needs reviewed every 6 months. And for children who are over the age of 5, the review should occur annually. The review should be actioned by the child's case manager or their caseworker, but it should be conducted by a health practitioner. And the pathway also has a particular focus on children and young people who are preparing to leave care. So usually these children are aged between 15 and 18, and they have the opportunity to undertake a specific health assessment and also the opportunity to build their capacity and their health literacy in terms of being able to transition into the adult health system. So the interagency team in Child and Family has program ownership of the out-of-home care health and the out-of-home care education pathway program. These programs have close linkages and should be implemented in conjunction because health outcomes can be achieved through education interventions, and good health can also increase health outcomes. Our team has developed a number of resources for caseworkers, including online learning modules, and there's some information on this particular slide about how to access those resources. The online learning modules have only been relatively new, have just been put together, but they emphasise more detail about the steps of the pathway than I could provide today. They also provide the contact details for all of the coordinators across New South Wales, and they include a message for caseworkers about the importance of this program. So it's more than just completing a form and providing that to a person within a certain time frame. It's really a program about improving health outcomes for children and young people, and that's so important in terms of improving their life outcomes and making an impact on their future potential. So that's the message we're really trying to get across with our material. As I said before, the contact details for the out-of-home care health coordinators are on this slide. Our local CSCs and our NGO service providers can also contact the coordinators and invite them to come along to your organisation and give a presentation and talk to you. So I'd really encourage that because they can provide a local flavour to the program and talk to you about how things operate locally on the ground. Anyway, their contact details are there, and so are mine, in case anyone would like to follow up with me after this presentation and obtain some more detail. Thank you very much, and I'll now pass back to Stuart.
Thank you so much, Angela, and obviously to all our presenters. We now have, well, we've got about 7 minutes left, so can I please, to everyone online, ask if you've got any questions for any of our presenters today, to pop them in the chat, and we'll use the few minutes we have remaining to discuss those. But yeah, can I just once again say a massive thank you to Associate Professor Elizabeth Murphy, to Associate Professor Melissa O'Donnell, to Associate Professor Stacey Blythe, and to Angela Tocker for those incredibly informative presentations. While we wait to see if there's any questions coming in the chat, I saw the discussion. Yes, we'll post a link to the slides to people who have registered for today's Lunch and Learn. I guess a question for myself, Stacey, if I can maybe come to you first. Firstly, I want to acknowledge and thank you for your 16 years plus as an authorised carer. It's safe to say that the carers are in short supply, and perhaps the lack of support you presented on today might be telling us part of the puzzle. But on the flip side, I guess my question is are there examples we can look at where carers are better supported, where we see those needs better met, that we can actually look to draw on? Yeah, I guess any positive examples of the carer support models we should be looking at more closely.
Yeah, thank you for the question, Stuart. I strongly recommend that we be looking at enabling carers to access services that are available to families that are biologically constructed. Nurse home visiting programs have been very useful at helping to keep families facing adversity together. But when they aren't successful and those families do require separation for a short or long period of time, those services don't generally follow the infant. So if an infant has already been engaging with nurse home visiting services and work is being done with that infant, why not let those services follow that infant into care and work with the foster care or the kinship care so that there's some continuity there? And ideally, if that infant is then restored back to maternal care, have the nurse follow again. This would provide in-home support for those carers and would enable them to ensure that the infant's developing in a typical trajectory.
Yeah, okay, fantastic. Well, thank you. And look, just while you're answering, there's a couple of questions popped up. So in terms of further information around what's being planned, we can take that question on notice. And in terms of sharing this information with preschools and childcare organisations, I think it's safe to say we'd all like to share this information as widely as we possibly can. So we're keen to finding audiences, but yeah, similarly, we'll come back to that. And I think Elizabeth, do you want to jump in on that?
Yeah, just to say that we've got a wonderful partnership happening with early childhood education. And recently I presented an educational session just on the first 2,000 days, not on the focus that we've had today with regard to out-of-home care. So yes, Brighter Beginnings gives us all the potential to work better together than we ever have before. And that's what's really exciting about this time.
Fantastic, thank you. And yeah, Kathy from SSI can always count on the question, I guess, about experiences or that anyone's research has looked at on a practical level, sharing information with cold community, or maybe is there also any variances in the research for supporting cold carers and cold children? Is that I mean, I guess a question I can pose more broadly to maybe to Melissa first, if that's something that's been looked at.
Yeah, we didn't specifically look at the cold community, but I think it's definitely an issue that needs to be looked at. I'm not sure, Stacey, whether there was anything in regards to the carers that you looked at in terms of that.
Actually, that's one of our next steps is to be investigating that, because it is an under investigated area in out-of-home care for both the carers and the children. So yeah, it's on our list.
And I can see.
Sorry, just to say that we're translating, we've developed some video resources and we're translating that into 5 languages. And also our blue book, the personal health record, which is such a roadmap for life in those first 5 years, that's translated into 19 languages and on the web. So that's also available.
Okay, great. No, fantastic. Thank you. And I can see there's a couple of comments there just about maybe where people are wanting to overcome some hurdles and how they might be able to escalate them. So I'm imagining that, Angela, that's a point in time when the health pathways might be an option.
Yes, absolutely. Yeah. And again, local out-of-home care health coordinators can, provide some support to caseworkers if they have specific barriers or, issues that need to be resolved. And people can contact me too for any further tips or advice.
And on Angela, the website, if you just put in out-of-home care pathway, it actually names and has the contact details of every coordinator in the state.
That's right. Yeah.
Yep.
Thank you.
Incredibly practical tip there. So yeah, there's an option for any barriers.
And it's got a great little animation that's wonderful to look at, to have a look at the out-of-home care pathway. I'd recommend it.
Even better. Thank you. Thanks for that. Look, I'm mindful that we've got a very tight hour, so we are coming to 1 o'clock on the dot. So can I just take the moment to bring us to a close, to once again say a massive thank you to our presenters today for an incredibly interesting and engaging hour. So again, thank you to Elizabeth Murphy, to Melissa O'Donnell, to Stacey Blythe and to Angela Tocker for your presentations today. Can I also thank everyone online for your interest in this area, for your work in this sector, and obviously hoping that today has been useful for you and gives you food for thought to take forward in your work supporting carers and infants and obviously their families. With that, a final thank you for joining us. Some information is just up on the screen about our next Lunch and Learn coming up in July, so further information will come out on the email. But look forward to joining everyone again next month, looking at improving mental health outcomes for children in out-of-home care. So again, a final thank you, and I hope you have a great rest of the day. Thanks for joining.
Thank you.
Thanks, Stuart.
Bye.